Now let's talk about fractures of the middle third of the face. The middle third of the face, the fractures which are common in that area usually is the fractures of the nasal bone and septum. Nose is very prominent structure, so any blow or injury to the middle third of the face, usually it is most likely to affect the nose. So nasal bone and septal fractures, and then naso-orbital, zygoma and zygomatic arch fractures. So all these are the bones that are present in the middle third of the face. Fractures of the orbital floor of the eyes and maxilla. Maxilla is the upper jaw and the structure and the bones in which the upper teeth are embedded. That's the maxilla. So all these bones are involved in the fracture or of the middle third of the face. So let's talk about these fractures of the middle third of the face. Here in this diagram you can see this is all the portion from the supraorbital ridges to the upper teeth, or the maxilla having the upper teeth. This is all the middle third of the face. Fractures of nasal bone and the septum. Septum is the partition between the two sides of the nostrils, between the right and left nasal cavity. Naso-orbital fracture. So fracture between the nose and the eye. Naso-orbital fracture. Fracture of the zygoma. Zygoma is the bone here present in the face, and this is the zygomatic arch that gives the cheeks the prominence. That's the zygomatic arch. So all these are involved in the upper face. Fractures of zygomatic arch and fractures of orbital floor of the eyes. Nasal bone and septum. Common and depth of the injury varies depending on how severe or bad is the injury. The involvement is depend on that, and the depth depend on that. Two types, usually the depressed fracture. Depressed fracture is due to frontal blow, the blow that comes from the front, and one is from the side, lateral blow. So if the blow is from the front, that's mainly caused the depressed type of fracture. Open book fracture. Open book, when we open the book, it's open book fracture, so it's depressed because of the frontal blow. Greater bones, comminution of nasal bones, flattening and widening of nasal dorsum. This is the nasal dorsum. It becomes wide open because it's like open book fracture. Then the angulated fracture is because of the lateral blow on the nose, unilateral depression, can fracture nasal bones and septum. Septal hematoma may form injuries of nasal septum. So with the lateral blow, usually it's the angulated type of fracture, and it can fracture the nasal bone and the septum. And with the blow hematoma, there is collection of blood in the septum, and it can also cause the injury to the nasal septum besides the nasal bone. So two types of fractures involve the nasal bone and septum. We have depressed due to frontal blow. We have angulated due to blow from the side of the nose. These are the diagrams of the fracture, and these are the forceps. One is the Walsham forceps, very commonly used. Then we have Ash forceps for elevation and for treating the fractures. Clinical features are of the fractures of the nose and face, swelling of nose and tenderness with the fracture. It's important to know that if there is fracture, usually there is very, very bad fast swelling occur in that region of the fracture. As compared to soft tissue injury, there is swelling and pain, but it's not as bad as compared to the fracture. There is ecchymosis around the eyes, periorbital bruises and ecchymosis. Nasal deformity and epistaxis, bleeding from the nose, is present. Crepitus and mobility of fractured fragments. Nasal obstruction and laceration of nasal skin. So all these are the clinical features associated with the fracture of the nasal bone and the septum. Most importantly, there is swelling, there is pain, and because of the swelling, crepitus is the feeling that occurs as a result of movement of the over the fluid. So crepitus is present, and nasal obstruction due to swelling or due to fracture is also present. Diagnosis is physical examination is important, and x-rays are very, very important in the diagnosis of the fractures. May or may not show fracture, must include Waters and occlusal view, right and left lateral view. So all these are the different views of the x-rays that should be performed. Treatment is if there is simple fracture, if there is one fracture, simple, sometimes no treatment is required and it heals on its own with time. Other fractures, closed or open reduction is performed. Best time for reduction is before edema appearance. So usually 5 to 7 days before the swelling appears. The best time for the reduction of the fracture is that time. In simple fracture, which is not compound, which does not involve the skin, just the bone, one straight line, usually it's healed on its own and no treatment is required. Treatment closed reduction is for depressed fractures, straight blunt elevator is used and the depression is elevated with the elevator. Digital manipulation, impacted and septal fragments, usually disimpaction with Walsham and Ash forceps. We saw the picture of these two forceps and they are used for the removal of impacted and septal fragments. Septal hematoma, if it's present, if there is collection of blood, it is drained and removed. No intranasal packing in some fracture is required. Unstable fracture, intranasal packing and external splintage. If they are unstable, they have a tendency to move. To fix them, it's important that we should put the pack and splints. Open reduction, when we do it, required for septal injuries. If the nasal septum is involved, open reduction is done. Healed nasal deformities, then we should do rhinoplasty or septorhinoplasty. If after the healing, if there is deformity, then we can perform the septorhinoplasty or septorhinoplasty, in which we do the repair of the septum and the nose. Next, naso-orbital fractures. This is the orbit or the eyes in between. Then this is the maxillary sinus. Maxillary sinus is in the maxillary region close, and these are the orbits. And this is the ethmoid sinus. Ethmoid sinus is, or ethmoid area is between the orbit and the nose. So ethmoidal air cells and medial orbital wall is fractured in the naso-orbital region. So here these are the ethmoid bone, and if you see this is the orbit, they are very close, and this is the naso-orbital region. Involves cribriform plate. This is the cribriform plate. Frontal sinus, frontonasal duct, extraocular muscle, and eyeball and lacrimal apparatus. So all these structures are involved in naso-orbital fractures. Clinical features of naso-orbital fracture. These bruises are very common in the periorbital region. Lot of patients with facial trauma and injury, you see they bruise on the periorbital region. So clinical features is telecanthus and cerebrospinal fluid leakage, pug nose and eyeball displacement, periorbital ecchymosis, orbital hematoma. All these are the clinical features. Diagnostic facial films to assess extent of fracture and facial injury. So these are the clinical features, and the diagnosis is by the facial films and CT scans. Treatment is by the closed reduction, which is reduced with ash forceps and stabilized by wire passed through fractured bony fragment. Internal wiring is done to keep the fractures in pieces in place. Intranasal packing and splinting kept for 10 days to immobilize the fracture site. Open reduction when there is a comminution of nasal and orbital bones. H-type incision is performed to expose the fracture, and nasal bones reduced under vision and bridge height. Reduction of medial orbital walls. So all this treatment is closed reduction, open reduction. Open reduction when usually where is comminution of nasal and orbital bones, small pieces are present, incision is given to reach the site, and then it is fixed. Restoration of medial canthal ligaments and intranasal packing. Fractures of the zygoma, which is the other bone present in the middle third of the face. It is caused by the fracture of the zygoma caused by trauma. Lower segment of zygoma is pushed medially and posteriorly, resulting in flattening of malar prominence and step deformity at infraorbital margin. So there is the zygoma is pushed medially and posteriorly, resulting in flattening of the prominence of the face. Clinical features, there is malar prominence flattening, step deformity of infraorbital margin. This is the infraorbital, supraorbital and infraorbital margin. So when the zygoma is fractured, you can see there is involvement of the infraorbital margin. Trismus and anesthesia because of the involvement of infraorbital nerve, oblique palpebral fissure, restricted ocular movements, and periorbital emphysema. All these are the clinical features associated with fracture of zygoma. Treatment and diagnosis, you can see the wiring done to keep the parts. So treatment and diagnosis for displaced fractures, open reduction and internal wire fixations. Different bones are fixed with the wire so they keep in contact. Exposed through lateral brow incision, reduction by elevator behind zygoma. The elevator is used to reduce the fracture. Transantral approach less favorable. Through the maxilla, the approach is less favorable. Exposure of antrum and stabilize. Aspiration of blood, reduction of orbital floor fractures, and removal of antral pack. This is the treatment of the fractures of naso-orbital region. Diagnosis is again by water view, CT scan and plain X-rays. Fractures of zygomatic arch. 3 fracture lines are present for the zygomatic arch. We have depression in area of zygomatic arch, local pain and trismus, limited mandible movement. So if the zygomatic arch is involved, all these features are present. Diagnosis: arch fractures, vertical skull view, water view is helpful in the diagnosis. Treatment is vertical incision, passage of elevator to temporal fascia, and reduction is performed. Stable fragments, then no fixation. If the fragment or pieces are stable, we don't need the fixation of the fragments. Fractures of orbital floor accompanies zygomatic and LeFor-2 maxillary fractures called blowout fractures. Clinical features of the orbital floor. These are the orbital floor. We have ecchymosis of lid, conjunctiva and the sclera. Anophthalmos and inferior displacement of eyeball because of the fracture of the floor of the orbit. The eyeballs are displaced inferiorly. Diplopia, patient can see double vision, and there is hypoesthesia and anesthesia of cheek and upper lip. So all these are the features of fracture of the orbital floor. Diagnosis again with the Waters view, teardrop opacity and CT scan and traction test. So all these are the diagnostic tests for the fracture of the orbital floor. Treatment is the anophthalmos and persistent diplopia. If present, the treatment is by the surgery. Exophthalmos is bulging of the eyeball out. Anophthalmos is inward bulging or inward pushing of the eyeball. Antrum packing is performed. Use of silicone or Teflon sheets reconstruct orbital floor. Other options can be the bone grafting, autogenous, infraorbital approach, and reduced by transantral approach. So all these are different treatment options available for the repair. Fractures of the maxilla. Maxilla is the bone of the upper jaw and which have the upper teeth. This is the maxilla. We have three types of divisions of maxillary fractures. Leaford 1, this is Leaford 1, which is the transverse fracture. Then we have Leaford, it's above and parallel to the palate, crosses lower part of nasal septum, crosses maxillary antra and pterygoid plates. So this is Leaford 1 type of fracture. Then we have Leaford 2, which is pyramidal shape. Here you can see going from the maxillary region all the way up in the pyramidal fashion, passes through the root of the nose, lacrimal bone, also through orbit, upper maxillary sinus, pterygoid plate, and common with zygomatic fractures. So this is the Leaford 2 type of fracture, and this is Leaford 3, where there is craniofacial disjunction because it is approaching to this portion of the cranium. Separation of facial bones from cranial bone passes through the nose root, frontal junction, orbital fissure, also through lateral orbital wall, frontozygomatic and temporozygomatic sutures, and pterygoid plates upper. So these are the three types of maxillary fracture depending on all the area which is affected by the injury or the accident. Leaford 1, 2, 3. 1 is limited, 2 is little more pyramidal shape, and the third is more extensive and there is craniofacial disjunction. Clinical feature and treatment of maxillary fractures. We have teeth malocclusion and interior open bite. The overlapping of the teeth is affected and they are not properly aligned and there is open bite. Elongation of the mid-face, maxilla mobility and CSF rhinorrhea is present. Treatment is restoring airway and stop hemorrhage, interdental wiring between the teeth, so to keep them in place, interdental wiring, intermaxillary wiring, open reduction, and interosseous wiring. So all these are different types of wirings done to connect the different pieces of the bones which are damaged or fractured. And wire slings can also use for the treatment. Diagnosis is again by X-rays, water view, postero-anterior and lateral views, CT scans. This was all about section 2, in which we talked about fracture of the middle third of the face. Thank you for watching sqadia.com.